Hello, my name is Andrew Waxler. I'm a cardiologist in Berks County, Pennsylvania, affiliated with the Penn State Health Organization, but I'm also the president of the state chapter, the Pennsylvania state chapter, of course, of the American College of Cardiology. I'm also a member of the Board of Governors, and as such, I represent Eastern Pennsylvania. Furthermore, I should add that I have had the pleasure over the years of working with the CVI organization, and as part of that, I have been one of the course directors and faculty for the CVI's annual Updates in Clinical Cardiology program, which is a fantastic course every fall. So with that, I'd like to say welcome to Heartbites. Here's my title for today's talk, and again, it's, as you can see, where have all the MIs and CVAs gone? Delayed presentation and worse cardiovascular outcomes, an unexpected consequence of the COVID-19 crisis. And again, that's me, and those are the titles. I should mention that we are recording this on May 19th, and I'm hoping that this will be relevant for at least a few weeks, if not longer. But as many, if not most of you have discovered, as I have, this COVID-19 crisis is moving so quickly, things seem to change day to day. So hopefully this will still be relevant when you watch it, but it was recorded May 19th. I should also mention that this is not a CME event. Unfortunately, we are not able to give CME, just share information. So here's my title. Here's my name. So let's start by talking a little bit about the COVID-19 crisis. As we all know, there's this terrible virus called coronavirus, which is ruthless against certain patients, elderly patients predominantly, patients with pre-existing conditions such as heart conditions or lung conditions or immunocompromised conditions such as cancer or rheumatologic type conditions, but really can affect even young and middle-aged healthy people. Again, I don't need to tell those of you watching this about the devastating effects of this horrible virus. So sadly, all of us have been pretty much obsessed and consumed with this virus and this pandemic over the past 2 or 3 months. We all recall that in December, we first heard about it. It was a big thing in China. And most of us, me included, thought, well, you know, I feel very badly for those people in China, but it's not going to affect us. Well, sadly, we were wrong, those of us who felt that way, as it spread out of China, initially to Europe. And as we all know, Italy became devastated with this virus in February and March. I should mention that the Pennsylvania chapter of the American College of Cardiology does have a partnership with the Italian societies. There's several of them, cardiology. And so we were indeed in contact with some of our brothers and sisters on the front lines in Italy. But again, this was something that was far away. Well, then in March, it came to the United States, first in Seattle, Washington, and then, of course, to major cities, including, but not limited to, New York, Boston, and yes, even to Philadelphia. So in our great state of Pennsylvania, we have had many cases of COVID-19, coronavirus. The majority of the cases are in either Philadelphia County or the counties surrounding Philadelphia, i.e. southeastern Pennsylvania. But make no mistake, this virus has been detected in patients in every county in the state of Pennsylvania. No county has been spared. So this virus is everywhere, although it is, of course, obviously going to be more concentrated where people are more concentrated, i.e. big cities. But you know that. Let's talk about what's been happening around our state and our country. Because certain pockets of this, of our state and our country have been overwhelmed, as I've already mentioned, Philadelphia, this is how many of our colleagues feel. A lot of our colleagues are working long hours, feeling overworked, and really overwhelmed. Fortunately for us cardiologists, we are not truly on the front lines. Yes, we do take care of some COVID patients. Yes, we are to some degree on the front lines. But the point I'm making is that the people that are really taking care of the majority of these patients are the pulmonary ICU doctors, the ICU nurses, the respiratory therapists, the ER doctors and nurses, and paramedics. Yes, we do get involved to some degree, but fortunately, as opposed to China and Italy, we've been a little bit protected as cardiologists. That being said, we have learned a lot over the last 2 or 3 months. We've learned that, yes, there are many cardiology consequences of this COVID-19 virus. We've learned that it can mimic a heart attack, an MI, a STEMI. A patient can come to the emergency department with chest pressure, with an EKG showing ST elevation, and even an hour or two later start to make enzyme. Those patients, traditionally, we've taken to the cath lab with the concept of D2B, door to balloon time. I mean, this is not new. We've been doing this probably for close to 20 years now, if not longer. But a funny phenomenon, an interesting phenomenon, is that a lot of these patients have normal coronary arteries. At the same time, we've also found that there's a cardiomyopathy which is associated with coronavirus, COVID-19. And it almost looks a little bit like Takotsubo. It's not exactly like Takotsubo, but kind of similar. And it's been postulated that this is related to a very potent myocarditis. There are other implications to the cardiovascular system, including clotting. Patients become sort of hypercoagulable. So we've learned a lot that, yes, indeed, the COVID situation does affect patients both who have pre-existing heart conditions, but then also can turn them into acute cardiac patients. Here's an early paper from China, and then a more recent paper from Italy. Of course, those two countries were hit hard before we were. But you know, something much more interesting has come out in the last few weeks, and I'm going to spend the majority of our talk today on that. And that is, not only does coronavirus, COVID-19, cause cardiac problems, but it actually seems to have this very bad, very powerful, and truly underappreciated, underreported, dangerous, indirect effect on cardiology, cardiac patients, heart care. In fact, it is true. So the answer to this question that I've posed here is yes. So just in the last few weeks, all of a sudden there are a plethora of headlines, of papers, of reports that are coming out. I'll read this. Fearing COVID-19, heart attack and stroke patients delay care. Doctors worry their patients with cardiovascular emergencies will be far sicker by the time they arrive at hospitals. Indeed, here's an article that just came out a week ago in the New England Journal, came out May 14th, and I do have the reference there. It's a very interesting article from a few doctors that come from a small hospital in Northern California, and they show some interesting trends. So in their hospital in San Joaquin County, California, you can see here the trend. This is January going into February, March, and April. If you look across the dotted line, that is the amount of ER volume, emergency department volume, over time. That's 2019. Now, if you look at the blue bars, that's 2020. But let's go to the next slide. Where I have the yellow arrow is where the first confirmed COVID-19 case was in their county. And where I have the red arrow is when the governor of California insisted that people shelter in place. And so what we've found is we want people to shelter in place. We want to do social distancing such that patients don't easily contaminate each other. Most of you know that a lot of patients are either initially asymptomatic or a real percentage actually are completely asymptomatic. And these people are particularly highly likely to spread the virus because they don't realize that they have it. And that's the whole concept of social distancing. Well, we want people to social distance and not go out to restaurants or go to sporting events where they're sitting right next to each other, but we don't want them to social distance from the emergency department. And if you can see here, after the red arrow for the remainder of March and into April, there was quite a drop in the number of ER volume. And we're going to come back to this a little later in the presentation. What this same hospital also discovered is that, yes, there are fewer patients coming to the ER. So people said, well, maybe that could be that people are healthier because they're staying at home. No, people are not healthier. And in fact, they noticed a 50% increase in 1 month of the number of cardiac arrests. Granted, the number is small. The N, it goes from 42 to 61. This is in one hospital. But as I will show you in the next few minutes, this is just a small microcosm of an overall trend. And indeed, in another paper that came out just about 2 weeks ago in the Journal of Emergency Medical Services, you can read this. This is the April data had just become available in early May. And again, the title speaks for itself. Complete April data shows alarming 911 trends for EMS calls during the COVID-19 pandemic. So this is in the MedStar Ambulance Company, which to the best of my understanding, this is a large ambulance company that works in multiple states. That's what I believe is the case. So let's look at the trend. In red is 2019. So this is the number of heart attacks in one of their ambulance services. Now, look at the trend over the months in 2019, but now compare it to 2020. What do you see? February going into March, going into April, the amount of heart attacks seen by this ambulance service was cut in half. Now, what about strokes? Same thing. In 2019, there was a flat, fairly stable, consistent number of stroke calls for each day. But notice in 2020, the number is cut by about a third. Again, the drop-off is in February to March. Again, perhaps small numbers, but it makes a point. The paradox here that I've already mentioned once, but I want to really emphasize is, while there are fewer heart attacks and strokes, this does not translate to healthier people. It actually translates to a significant increase in the number of cardiac arrests. Indeed, look at the trends here in cardiac arrests per year. In 2020, the number of cardiac arrests on a daily average is almost double. Actually, it's really double, if not a little bit more than double, that of 2019. And even equally or worse is the number of people that are, quote, dead on scene, which is the blue line. So again, it doesn't take a genius to see these trends here, that there are more cardiac arrests and more patients that are dead on arrival or dead at the scene. And this was actually first, I don't know if it was first, but it was identified by TCT several weeks ago in early April, the mystery of the missing STEMIs. And when I read this article, there were a lot of interesting quotes that came out of it, and I'm going to share a few quotes. I'm going to read them, even though, yes, I'm sure everyone there can read. I think people are terrified at home, so they're not showing up in the emergency departments, which are totally collapsed. It could be just a very weird week, but it really raises a concern that patients with cardiovascular complaints or concerns may not be presenting to medical care because they're afraid of the hospital, they're afraid of COVID-19. And finally, the most worrisome quote, this comes from England, obviously, or Britain. It is conceivable that in the UK, the deaths that eventually could be attributed to COVID-19 will be dwarfed by the deaths that have occurred because of the absence of otherwise routine medical care. That is a scary, scary quote, and I hope that that is not the case, but it could be. Just today, this is hot off the press. This was published by another member of the Board of Governors from California, who told me about this article today, and I found it. This is from the Kaiser Permanente group in Northern California. And as you can see, again, in early March was the first reported death from COVID-19. March 19th was the shelter in place. As you can imagine, the number of COVID-19 patients went up dramatically. But as we've also shown, the number of acute MIs was cut in half. So again, notice the 2019 trend is pretty flat, whereas the 2020 trend is cut in half. The emergency physicians put out an article that after they had polled the general public, and they found that 29% of patients admitted that they were either delaying or just canceling altogether medical care because of fear of COVID-19. My hunch is that that is low, that the real number is much higher. I think that perhaps some patients were just saying, we're not answering truthfully. But 29% of people did actually admit it. But what can we do to get people back in the emergency department? Well, it's going to take a few things, right? It's going to take public education. It's going to take, hopefully, hopefully this COVID-19 crisis is starting to wind down. But more importantly, I think we need to really go through with a fine-tooth comb our triage procedures and make sure that patients are being triaged rapidly so that if they have respiratory symptoms or symptoms that are highly suspicious for COVID-19, the big three have been fever, cough, shortness of breath. Those people are triaged to one direction and everybody else is triaged to another direction. So you have two separate waiting rooms and really sort of two separate ERs. Of course, the problem with this is obvious, and that is sometimes COVID-19 presents in an atypical fashion. And I already told you that it can present like a heart attack. So this is not perfect, but I think it would be helpful. And indeed, in an article that I showed you earlier from the New England Journal a week ago, from San Joaquin County in California, the Adventist Hospital actually has taken this approach. And I'm going to show you a blown up version of this that I expanded. So as you can see here, patients in their hospital, their emergency department, come into the main entrance and are immediately screened and immediately either sent to the left, which is blue, which is non-respiratory, or to the right, which is red, which is respiratory. Again, not perfect, but at least it gives some fighting chance for a patient who comes to the ER with a broken ankle to not be sitting next to someone with COVID-19 in the waiting room. And indeed, if we go back to the chart that I showed you earlier, the volume timeline, I did blow it up a little bit here. You will see that, again, mid-March is when the shelter in place started. But in April, in the middle of April, this hospital redesigned their ER, as I just showed you. And 2 days later, April 19th, they started a newspaper campaign. 2 days after that, they did a social media campaign. And there is a subtle but definite increase in the ER volume. So again, the numbers are small. It's a trend. It's not scientific. But I do think that there is value in looking at this. So I'm going to take a couple minutes before we wrap up and say, what about elective cardiovascular procedures? We all know that there are some things in cardiology that are elective. However, we also know that the vast majority of invasive cardiology procedures are not elective. One could argue that a pacemaker generator change is elective because you usually have 3 months. Okay, what happens if a patient shows up and they've already used 2.5 months of their 3 months of usual time, and they come in and their battery is really almost done, and they are pacemaker dependent? So there are shades of gray. There's elective, and then there's elective. The thing that a lot of us have feared is that for the last 2 months, we cardiologists have put off anything that's not really life or death, or maybe slightly below life or death, that's not very, very serious. Anything that's sort of in the middle of the spectrum, I believe that most cardiologists across our country have indeed delayed. Why have we delayed this? Well, we delayed this because we were told to do so. In the middle of March, March 18th to be specific, CMS instructed us, both individuals and hospitals, to do this. Now, if you read this headline, it says CMS releases recommendations. Now, recommendations is a soft word, and you could argue, well, you know, it was a recommendation, we didn't have to do it. Well, I blew up the first paragraph. If you read the first paragraph, it says that CMS announced all elective surgeries, blah, 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 would be delayed. So there's no recommendation in that first paragraph. There was an announcement that these procedures would be delayed. So the concern is, are we putting those patients at risk? Obviously, some of them that have very, very elective procedures, probably not. But a lot of us are a little bit worried, and many of us feel that now might be the time to reopen our cardiology diagnostic centers and invasive hospital procedures. I want to apologize that this graphic turned out so crummy. I tried really hard to make this pretty. This is a screenshot from what you can get from the Pennsylvania state government. I've shown you on the bottom the source, and it's a really neat thing. But the key here, that even though it doesn't look pretty, it shows that in the blue on top is Pennsylvania, the state of Pennsylvania. As you can see by following the 7-day rolling average of new cases, so this is new cases being diagnosed on a 7-day rolling average, you can see that over the past week or so we hit a plateau, and now clearly the trend is going down. Right below the blue is purple, and purple is Philadelphia. So you can see that a large percentage of the cases are from Philadelphia. If you notice, you will see that all the other counties in the southeastern part of the state are trending down as well. Schuylkill, which is at the bottom, is sort of flat. But the point is, I think it's clear to most of us that, thank goodness, we may be past the peak. Not saying that everything is great, but we may be past the peak. So because of that, just in the last couple of weeks, there have been several publications suggesting how to restart elective cardiac cases. And I won't go through all these, but just be aware that there is some literature and recommendations out there, including from my parent organization, the American College of Cardiology. I did a screenshot of this today. So there are resources out there to help you get your cath lab, your EP lab up and running. What virtually everybody I know is doing is they're testing the patient for COVID-19 about 48 to 72 hours before the procedure. Obviously, it takes time to get the result back. You want to do it early enough that you get the result and can do the procedure. You don't want to do it 2 weeks ahead of time because then, you know, who knows what's happened to that patient. So as we go back to bringing our patients back into the cath lab, the EP lab, our nuclear lab, I'm the director of our cardiac rehab. We've been back on doing cardiac rehab for the last week. It's all about risks and benefits. This is what we do as cardiologists and as cardiovascular team members. We do risks and benefits. That's what we do. This is nothing more than a risk-benefit ratio. When we made the decision about 10 days ago to start the process of getting our cardiac rehab up and running, we weighed the risks and benefits. We're only allowing one patient at a time. We screen them well. We wipe down everything very carefully. They wear a mask. So we're using all kinds of logical precautions. We have a term in radiation safety. For those of you watching this, those of you who are cardiologists have had some time, most likely in the cath lab or the EP lab or the nuclear lab, and you had to learn a term called ALARA, A-L-A-R-A, pardon me, A-L-A-R-A, ALARA, which is a radiation safety term which stands for as low as reasonably achievable. So you want to get the radiation exposure to the patient, but also to the doctor and the staff as low as reasonably achievable. My colleague and friend, star ACC governor representing Maryland and future chairman of the Board of Governors of the ACC, Joe Marine, cleverly coined this term when I was talking to him on the phone last week, called ASARA, as safe as reasonably achievable. That should be our mantra. We need to reopen cardiac rehab and our stress lab. We need to get people into the cath lab, but we need to do it safely and cautiously. The ACC is there to help. I always like to remind people that the ACC's mission is to transform cardiovascular care and improve heart health. And that mission statement is as accurate during our current crisis as it is at any other time. So just to summarize, there are some articles in the lay press. This was in Forbes magazine. I don't typically read Forbes magazine, but I found this article. This is a letter to the editor that you can't read, but I wrote this to the Philadelphia Inquirer last week. It's not about this issue. It's actually about a different issue, but be aware that myself and about 4 or 5 of us across the state of Pennsylvania are doing a letter to the editor campaign to hit all the major newspapers in the state of Pennsylvania within the next week, bringing this issue to the forefront. We've done local television shows, we've done local radio shows, and we're doing this video. So this is important. By the way, if you do Twitter, I'm going to take 10 seconds to say these are 4 very good Twitter handles that you can follow and gives you up-to-date information about the state of the cardiovascular world in Pennsylvania, but also nationally, as the bottom one is the American College of Cardiology Advocacy Twitter handle. If you have any questions, you could reach out to Mark Hartnick, and here's his email. Feel free to share this link with anyone who might be interested in the information, and please let us know if there are any topics that interest you. Thank you for watching this Heartbites segment. Hopefully you learned something. If you have any questions, you can reach me through the CVI, or my email is Waxler, so AWAXLER @comcast.net. For more information about CVI Heartbites or CVI educational programs, visit us at CVI, that's CVI Philadelphia, all one word, .org, and follow us on Twitter at CVI_Philadelphia. And you can also use the hashtag Heartbites. You can see everything is on there. Thank you so much. Have a great day. Stay safe out there. And hopefully this will be going away in the next few weeks. Fingers crossed.